So I am joined today by Dr. Ursula Matulonis. She's the medical director and program leader of the Medical Gynecologic Oncology program at the Dana-Farber Cancer Institute, as well as a professor of medicine of a little school you might have heard of called Harvard Medical School. So tell us a little bit more about what your research focuses on.
So my research focus really currently in my group is to develop new therapies for women with recurrent ovarian cancer, and then we're also developing trials for recurrent uterine cancer as well. Since before 2014, the last drug or drugs were approved in 2006 for ovarian cancer, advanced and recurrent ovarian cancer, and that was the combination of carboplatin and gemcitabine. So it took nearly 10 years from 2006 to 2014, actually the end of 2014, to get a new drug developed. And why it took that long? Well, I think it took that long because a lot of the clinical trials that were devised back in the early 2000s, mid-2000s, lumped ovarian cancer together and treated all ovarian cancer as one cancer. And we know that that's not true. So we know that the different histologies of ovarian cancer not only behave clinically different, but also look different from a histology, so under the microscope standpoint, but also from a molecular or genetic standpoint as well. So the identification of high-grade serous ovarian cancer, which is the most common subtype of epithelial ovarian cancer, we know about half of those women who have high-grade serous ovarian cancer have some underlying deficiencies or defects in how DNA is repaired. It's called homologous recombination deficiency, or HRD. HR, or homologous recombination, is the way that a cell responds to and repairs a nick and break, a double-stranded break in DNA. So both of the strands of the DNA get broken as opposed to a single-strand break. So the identification of this being a vulnerability in high-grade serous ovarian cancer led to very early studies in laboratory dish of cancer cells that had also underlying BRCA mutations, so breast cancer genes, or BRCA, that's what we'll call it for short, showing the exquisite vulnerability of those cells to drugs called Parp inhibitors. And Parp inhibitors work by the concept of called synthetic lethality, meaning that you have to have two genetic events happening simultaneously in order for that drug to work and lead to cell killing. Yeah. So in the example of high-grade serous ovarian cancer, there has to be problems in homologous recombination or the presence of homologous recombination deficiency, or HRD, meaning there's an underlying mutation within this gene called BRCA1 or BRCA2. Those proteins are very important in helping DNA repair itself. So if there's an underlying problem, underlying mutation, that's one of the genetic hits that has to be present in order for Parp inhibitor to work. The second is the presence of a Parp inhibitor. What Parp inhibitors do is they're pretty complex, but they work on if there's a single strand break. So the single strand break, Parp enzyme is like an ambulance or a first responder, rushes to the site of the break, the single strand break in the DNA, and brings a host of other friends with it to help the DNA repair itself. So if single strand breaks are not getting repaired because of the Parp inhibitor, it actually, the DNA repair process shifts over to double strand break repair mechanisms. And so if you have this underlying BRCA mutation, the DNA cannot repair itself. So that's what's called synthetic lethality. And the recognition in the Petri dish that BRCA mutated cells have exquisite sensitivity to Parp inhibitors really has led to multiple phase 1, phase 2, phase 3 studies of Parp inhibitors in ovarian cancer. So I've already mentioned that the cancer cells that have underlying deleterious, meaning the mutation within BRCA gives rise to problems with DNA repair. Those cancer cells are very exquisitely sensitive to PARP inhibitors. But then, I already told you that half of all high-grade serous ovarian cancer is also sensitive to PARP inhibitors. So maybe a little bit less so, but still sensitive. So that's led to trials using PARP inhibitors as primary treatment.
Okay.
So for a woman who has recurrent ovarian cancer and she needs to be treated, so she'd be treated with chemotherapy, but if there's an underlying BRCA mutation, either a germline, meaning every cell has it, or something called a somatic or tumor mutation, there are now 2 PARP inhibitors that have been FDA approved for that setting, olaparib and then rucaparib. And then also randomized phase 2, and now at least 3 phase 3 studies comparing the PARP inhibitor to placebo have been tested in women who have platinum-sensitive recurrent ovarian cancer, who are receiving platinum, and the cancer is responding to it. So typically what has happened in practice is that once patients are diagnosed with platinum-sensitive recurrent disease, they receive a platinum doublet, they go into remission, they stop chemotherapy, and we don't have any maintenance therapy like tamoxifen or aromatase inhibitors like in breast cancer. So PARP inhibitors have been tested in these randomized settings against nothing and shown to keep the cancer in remission longer compared to what would be considered standard of care. And if you're on chemotherapy, you get 6 to 8 cycles, and that stops. And all of these trials that have led to FDA approval, so I mentioned 2, rucaparib, olaparib as treatment, and as maintenance therapy, women who have platinum-sensitive recurrence, olaparib and niraparib, both of those drugs have received FDA approval in the platinum-sensitive recurrent setting if the cancer is in response to the platinum. There are also multiple trials ongoing of testing PARP inhibitors in newly diagnosed patients as well, either combined with chemotherapy for a drug called veliparib, with a drug called veliparib, or as maintenance therapy post-chemotherapy, and that would include niraparib and olaparib. The problem with combining chemotherapy and PARP inhibitors is that there's overlapping bone marrow suppression. Really strong PARP inhibitors do 2 things. They inhibit the enzyme Parp, which helps repair single-stranded DNA breaks. But they also do something called Parp trapping. So as the DNA nicks and needs to be repaired, the Parp enzyme rushes to that site of repair. The Parp inhibitor causes that Parp enzyme to get stuck on the DNA. It's called trapping that enzyme or Parp onto the DNA. It doesn't let it go. It's like glued on there. If the Parp enzyme is glued on there, DNA repair cannot happen. So that leads to also increased cell death. So PARP inhibitors really have to have these 2 capabilities. Inhibiting PARP enzyme, but also leading to PARP trapping. And rucaparib, niraparib, and olaparib do this very well, essentially equivalently. The one drug that doesn't do it as well is veliparib. It inhibits the enzyme pretty well, but it doesn't PARP trap very well.
Gotcha.
So that's why you can combine it with chemotherapy.
So for this, what does this, I guess, type of research really mean to the ovarian cancer community right now?
So great question. So it's really transformed the way that we treat women with high-grade serous ovarian cancer or high-grade endometrioid cancer, where we know there's these underlying defects in DNA repair. So most of our patients with recurrent cancer will be potentially eligible to receive a PARP inhibitor. Now, something else that we're looking at, and we're looking at this, but other groups are looking at this as well, and I mentioned this before, is if there's inherent resistance to a PARP inhibitor, or the patient's cancer progresses through a PARP inhibitor, what are the next strategies? Women do like to take these drugs. They're oral. They don't have to come into the clinic to get IVs in.
I'm the same way.
Right.
If I can avoid a doctor's trip, I will.
I mean, they have side effects, but these side effects tend to get better with time. So we're looking at PARP inhibitor combinations. So combining the PARP inhibitor with drugs like anti-angiogenic drugs, drugs such as immuno-oncology drugs, other biologic agents that don't necessarily have overlapping side effects with a PARP inhibitor. PARP inhibitor toxicities are bone marrow suppression. So what you don't want to do is add a highly myelosuppressive chemotherapy on top of a PARP inhibitor, because then you have to end up dose reducing some of those drugs, and you get a lot of side effects. So what our group has looked at, as well as other groups, combining PARP inhibitors with other drugs that make a cancer cell, which initially has DNA repair intact, we call it HR proficient, and changing that cancer cell genetic milieu into a cancer cell that's HR or homologous recombination deficient, meaning it would be more susceptible to a PARP inhibitor when you added another drug to it.
Gotcha. Well, thank you. I appreciate the fact that you are really going in depth with what you guys are working on. I definitely did. So thank you.
You're welcome.
So I like you, Dr. M. Okay, so I'm gonna hop us back over here, and I do want to ask you this question.
Yes.
And we touched on it a little earlier, but genetic relationships between breast and ovarian cancer.
Yep.
And what are the implications for patients with ovarian cancer?
Sure. So the genes that are implicated in breast ovarian cancer susceptibility are BRCA1 and BRCA2. So it is now standard of care around the world, internationally, that any patient who walks through the door who's newly diagnosed with ovarian cancer, peritoneal cancer, or fallopian tube cancer, and we think about those cancers synonymously, meaning identically, that patient should undergo genetic testing. Now, that genetic testing should be a minimum of BRCA1 and BRCA2 genes, but now there are panels called panel testing, where the number of genes can go up to 35 or so, even sometimes more, expanding the number of genes being tested. So really you're doing two things by testing all ovarian cancer patients. You're seeing whether or not that patient has an underlying germline that she inherited from either mom or dad. And if she tests positive, then something called Cascade Testing occurs. And that means that other generations will and should get tested. So if it's a mom who's 60 years old and is diagnosed with what we would call a deleterious BRCA1 or 2 mutation, she's diagnosed with ovarian cancer, gets gene tested during her upfront chemotherapy, genetically tested, found to have a gene, and she's got daughters. The daughters should be tested. Sisters should be tested. So the entire family, where there's a direct bloodline where you can share genetic material, those patients. Also men, because if BRCA2, even BRCA1, there can be certain cancers like male breast cancer, and with BRCA2, melanoma, pancreatic cancer can be associated with BRCA mutations, BRCA2 mutations specifically.
And how do we identify and monitor individuals that are at high risk? And I know you've touched on a little bit as far as making sure that you're tested, but what happens when they've reached that point?
Yeah, so I think it really depends upon the patient's age and where she is in childbearing. You know, clearly if you find a mutation in somebody who's 20, the treatment is going to be different than somebody who's 60. So somebody who's past childbearing age, who's found to have a deleterious mutation, germline mutation, that patient should undergo both ovaries removed as well as both fallopian tubes removed, because we think that a certain percentage, not all, but a pretty high percentage of ovarian cancers actually start in the fallopian tube. So it's important to remove both the ovaries and the fallopian tube. And then those patients should also consider
now that's for a patient that's past the childbearing age, right?
Correct.
Okay, so for
yeah,
those
so
that
should
are
be,
younger?
I mean, so those are younger. It depends upon what they want to do with kids. I mean, obviously, a 20-year-old having her ovaries taken out is a big deal.
Yeah.
And she goes into instantaneous menopause, and that's not a good thing.
Right.
There's symptoms that are, menopausal symptoms that happen. Cognitive problems that can happen with the lack of estrogen, especially at age 20. I mean, obviously, if it has to happen, it has to happen. But typically what will happen is that post-childbearing, that woman will then reconsider having ovaries and fallopian tubes taken out. So you could monitor those patients with transvaginal ultrasounds and CA-125, but we know that they're not perfect tests. The CA-125, especially in premenopausal women, can vary a lot with menstrual cycles, with benign ovarian cysts, with upper respiratory infections, just menstruation in general. So the CA-125 becomes not as good a test. And transvaginal ultrasounds also, again, done on an every 6-month basis or every year basis, there's not a great trial that shows that combining those two tests for women who have, a high risk or higher risk of developing ovarian cancer, that those tests are going to be able to pick up a cancer early.
And
so you can't depend on them.
So I know we talked quite a bit.
Yeah.
Or I would say you. I'm taking credit here. I listened to it, but quite a bit of Parp inhibitor information, and you touched a lot on the research. And if you could elaborate, if you haven't touched on this already, what are the benefits versus the challenge of Parp inhibitors, and how does it impact survival of patients?
Yeah. So Parp inhibitors are challenging from a resistance standpoint, because the cancers, once exposed to Parp inhibitors, eventually at some point will become resistant to the Parp inhibitors. So development of post-Parp inhibitor resistant treatment strategies are critical, and that's what we talked about, combination therapies. The challenges are toxicities, so side effects.
And what kind of side effects would be looking at? So
side effects, of the 3 that are approved, there are very much some overlapping side effects. So for example, bone marrow suppression, I've already mentioned this.
Right.
So drop in white count, drop in red blood cell count, drop in platelets, and potentially even sometimes requiring a red blood cell or a platelet transfusion. Fatigue. I should also mention with the drop in blood counts, there's also this small but reported risk of a secondary leukemia, so AML, acute myelogenous leukemia or myelodysplastic syndrome, that happens in about 1 to 2% of patients. But it's interesting that in randomized trials on the either Parp inhibitor versus placebo, even on the placebo arm, there are reports that are pretty equivalent to the Parp inhibitor arms of that same risk of AML or MDS. It really is because of the pre-treatment with platinum, repetitive treatments with platinum, other drugs that are alkylating agents, do over time increase the risk of secondary leukemias. It's a very small risk, but it's reported.
Right.
Fatigue, gastrointestinal side effects. These GI side effects are nausea, occasional vomiting, just not feeling hungry, anorexia, meaning just, like you look at food and it doesn't really appeal to you.
I guess that's probably where the loss of weight kind of correlates.
It's interesting that these gastrointestinal side effects will occur for typically the first 1 to 2 months, and the same is true of fatigue as well. But those side effects tend to get better over time.
Okay.
So I think it's important to remind.
So there's a light at the end of that tunnel.
Yeah, there's a light at the end. So I think you have to remind women that those side effects can occur. Certainly report them in. Sometimes even giving her a prescription for an anti-nausea medicine. But to say that those side effects get better over time. It's also important that with drop in blood counts, that sometimes the blood counts get checked more frequently than just once every month. And in fact, with the drug niraparib, there's really a call, even with a package insert, of checking blood counts more frequently, even once a week until you get past that 1 to 2 months period, because the counts can drop even pretty precipitously in just within a week or so. There are other side effects that are more specific to the Parp inhibitor. So, for example, olaparib and rucaparib can cause these very slight elevations in the serum creatinine. Rucaparib can cause a slight elevation of liver function tests that tends to get better over time. Niraparib, because it blocks the norepinephrine receptor, can cause hypertension, tachycardia, and headaches. So patients have to be warned, especially if they have underlying hypertension, to be monitoring their blood pressure with home blood pressure cuffs if they go on a drug like niraparib. There's a small risk of pneumonitis that's been reported with olaparib, but meaning inflammation of the lungs, but it probably can happen with all three of them. There's a slight increased risk of something we call infections and infestations as per the FDA package insert. So these would be, cellulitis, urinary tract infections.
All the fun stuff.
All the fun stuff.
Yeah.
There's a slight increased risk of those with Parp inhibitors, especially olaparib. At least that's what's in the package insert. Again, minor risk.
Okay, so now I have taken us down. I was the Debbie Downer here, and I took us through all the negatives of the challenges. But let's talk about the benefits of those. Let's talk about the good stuff now.
I think the benefits have been, as I said, why are Parp inhibitors are used as treatment, primary treatment, and at least then for olaparib and rucaparib, olaparib has about a 33% response rate in its FDA approval right now, and that means underlying germline BRCA mutation and received at least 3 prior lines of chemotherapy. And that duration of response is around 8 months. For rucaparib, germline BRCA mutation, somatic or tumor BRCA mutation, at least 2 lines or more of prior chemotherapy. Response rates are a little bit better because those are typically a little bit less heavily pretreated patients, around 50%, and durations of response slightly longer, around 10 months. With the maintenance therapies, the primary endpoint of those 3 studies, looking at olaparib, rucaparib, and niraparib, the primary endpoints have been something called progression-free survival, meaning how long does the cancer stay in remission for before it comes out of remission? And in all those studies, the progression-free survival, meaning the amount of time that the cancer stays in remission for, is longer, significantly longer, than for nothing, which is not surprising, but it's significantly prolonged. Now, to date, none of those phase 3 studies, in addition to another phase 2 trial called Study 19, which was the first trial to look at maintenance olaparib, none of those studies have actually shown that by taking a Parp inhibitor, you'll live longer. So the overall survival benefit has not been demonstrated. And again, sometimes more time is needed for these trials, but they may never show an overall survival benefit. And there are lots of theories around that, really because for patients who are on the placebo arm, eventually they're going to get a Parp inhibitor. So they're being exposed to these drugs at some later time point. And also, the good news is that our patients with recurrent ovarian cancer do have more options for treatment. So we have been able to really keep patients in remission longer. And time will tell about phase 3 studies whether or not we're seeing an overall survival benefit with Parp inhibitors, but to date, we're not seeing that.
All right, so Dr. M, we would like to know at Ovarcome, what message would you have to our survivor community that is currently undergoing treatment for ovarian cancer?
So I think several messages. One, importantly, is to be advocates for yourself, but advocates for the entire community. So advocates for yourself would mean making sure you're getting genetic testing. And if you've gotten genetic testing, let's say 5 years ago, understand what the genetic tests were. So you might need to be retested to look at the camera, to retested to expand that panel of genes because we know a lot more, and there are at least 11 high-risk genes that confer an increased risk from a hereditary standpoint for ovarian cancer, whereas a few years ago it was really BRCA1 and BRCA2. So be self-advocates for understanding genetic testing, getting genetic testing, making sure your family members get genetic testing if you are positive. Understanding what clinical trials are available, understanding your options, searching for clinical trials. Clinicaltrials.gov is a great resource that at your fingertips on the computer, you can see exactly what trials are openly and actively recruiting, some that are closed, and actually some results. And in fact, clinicaltrials.gov has results on it that sometimes are not even published because that website, federally sponsored website, requires that. And then advocating for the entire community, really advocating against the drop in National Cancer Institute funding. If there are calls for taking away Department of Defense funding, yelling at your senator, yelling at your U.S. representative, that is not okay because we have to maintain and increase funding for ovarian cancer research. So I think those are my messaging. Self-advocates and really advocating for everything, being potentially a more professional advocate where you go on NCI committees, review protocols. That would be something else to do. And I also think taking care of yourself.
Yeah.
I think making sure you're on treatment, or even if you're off treatment, sleeping well, getting rest, exercise, eating well, really decreasing stress, and making sure your life is as fulfilled as possible, and that you're doing activities that are pleasurable.
I think everyone can benefit from
those. I think you're right.
I think you're right. I'll be following those instructions myself when I get out of here. But one more message, because I know being a self-advocate is obviously very important, but another thing that's important is awareness. So how can one utilize an organization such as Ovarcome in order to raise awareness?
Yes. Well, your organization, Ovarcome, sounds like you guys do a lot.
We do.
You do.
And our president, Runcie, you guys can't see her, but she's here, and she's an amazing woman.
Yeah. So certainly, I'm sure you have a great website. So I think women can gain access to your website, understand what your organization does, because it sounds like it does. Awareness, so education. So educating women, educating the medical community about the different treatments available. Funding research, which is really critical because of the NCI drop. Foundation support for our research is absolutely critical. And it sounds like your website also does seminars. So seminars is part of research, and it also has the capability of providing patient funding when somebody is, for some reason, not able to work potentially during treatment, around holidays, so you can buy presents for loved ones. So that's really important.
Well, thank you so much, Dr. Allen. We appreciate your time.
You're welcome.
And
it's been a real
all
pleasure.
of the plethora of information we got today. So thank you so much. I've learned a lot about PARP inhibitors. I'll tell you that.
That's right. Yeah.